medicine, gastrointestinal disorders. So I have a lot of patients with IBS as well. Also do hormone replacement therapy for both men and women. And this is Dr. Sarah Williams. And Dr. Sarah, I'll let you introduce yourself.
Yes, hi everyone. I'm so excited to be here. This is a topic that has so much confusion around it. So I hope, like Dr. Mary said, that you leave with some clear answers and more information about hormone replacement. I've been at Modern for over 6 years. And like Dr. Mary, I specialize in hormone replacement as well as GI conditions and general preventative medicine.
Awesome. Awesome. And this is the ethos of modern med. So some of my big kind of things that I think are really important in medical practice, but also just in the world in general, is transparency. So we really want you to know how our program works. I also really care about transparency when it comes to messaging on social media, understanding risks and benefits. Which leads me to our second ethos, which is no BS. There's a ton of BS out there. Raise the hands who's sick of like how much BS is on social media. You see, yes, yes, yes. Okay, we are all in agreement. It's really frustrating. And it leads people to be in a place of analysis paralysis, where it's like, what can you trust? What can you not trust? Who can you trust? And it's confusing, where one person is saying you should eat carnivore, the other person saying go plant-based, and hormones are going to kill you, or hormones are the fountain of youth. And usually the truth lies somewhere in between most of these things. But at Modern Men, we really stand for no BS. We want to be a trusted source. We want to be a signal amongst all the noise that's out there. And we really focus on being evidence-based. So we have a ton of research and we want to use that. And we need more research, especially in the realm of women's health. We're truly integrative, which means that we prescribe medications, we focus on diet, exercise, and lifestyle. We treat the entire whole person, and we're boutique. So we're a small practice, and that allows us to spend more time with our patients. At one point, I wanted to scale and have a huge telemedicine practice, and now I'm so happy to have a very small boutique practice where I know all of my patients' names and their family members and intimate things that are going on in their lives, and that really brings me a lot of purpose. Anti-fads and trends. There's a lot of clinics that will jump on a fad because it brings in money, and we really want to stand in an authentic tone of what we believe and stand for. Dr. Williams is going to kick us off about what the actual hormones do in our body, and let's go from there.
All right. So yeah, these are the main hormones. We'll mostly be focusing on estrogen and progesterone today, but these are our main sex hormones, and they really have a big role on how we feel and function as a whole, as you can see here. So estrogen plays a lot of roles in our body, everything from mood support, our energy, sex drive, vaginal lubrication and tissue, and then also with our bone health, heart health, brain health. Progesterone, we always like to classically call this the volume of our uterus. It binds to our GABA receptors, so it often helps with mood, anxiety, and sleep, PMS symptoms, things like that. And then testosterone, of course, very important for sex drive, but also our muscle mass, strength, motivation, energy. And actually, it's one of those things that I think is so interesting when women find out that we actually make more testosterone than estrogen, because estrogen we always think of as our dominant hormone as females, and obviously they're all very important, but we actually make more testosterone than estrogen. So it's very important that we're looking at that too.
Awesome. So in menopause, about 50% of postmenopausal women develop symptoms of vulvovaginal atrophy, and which is like when the tissue changes of the vulva. It includes vaginal dryness. That's half of women. 85% of women will experience hot flashes, and yet only 25% of women will seek treatment for hormone replacement therapy or just treatment in general, because we have things that are other than hormones that are there.
So, what is perimenopause, menopause? There's often a lot of confusion around this. So, perimenopause is really referring to the years leading up to actual menopause, and this can last up to 10 years before actual menopause. And this is really just the transitional period between our reproductive years and menopause itself. And so, you start to often experience symptoms that are related to your hormones changing. One of the key signs here is irregular cycles. So, they can be more frequent, like less than 21 days, for instance, or even more spread out, like more than 35 days apart. And they really just kind of fluctuate and can be all over the place. Everyone's experience is different, but that's one of our keynote symptoms that we are in that perimenopausal transition. And then, of course, all the other associated symptoms that we'll keep elaborating on, like hot flashes, night sweats, irritability, having a hard time sleeping when you've never had that difficulty before. People will say, I just don't feel like myself. Weight gain is very common, low sex drive, all of those things that come with these hormonal changes that we experience. And so the average age of perimenopause is 47. And then menopause is really referring to when we have not had a period for 12 months consecutively. So for 1 year, you don't have a period, we can say, okay, you are menopausal now. Average age of this is 51. But we still find that even though you might not be you're not having a period anymore, that symptoms might persist.
Yeah. And it's always funny when somebody's like, am I postmenopausal? And you won't know if you are postmenopausal until it's been a full 12 months of not having a period. And then you realize that 12 months earlier, you went through your last period, which was your date of menopause. So menopause is always a question mark until it's been 12 full months, and then you know, okay, now
Hmm.
I'm postmenopausal.
Yep, exactly. And here, I think this is such a good representation of what is going on. And so, with these graphs, each of these graphs is looking at how your hormones are changing over 6 months. So, on the left side, we're looking at when you are regularly having a period before perimenopause. And so, we see estrogen, progesterone, those dark lines, and how they change with every month. And then we see in this middle graph what's happening in perimenopause with our estrogen and progesterone. So they are literally all over the place, which is why you are feeling often all over the place. I heard something the other day where it was like, then perimenopause, the one consistent thing is inconsistency. And so that is exactly what we see here with the graph. And then on the right, we see what's happening with postmenopause. Essentially, the estrogen, progesterone, those bottom two lines are flat lines. So our ovaries are not able to, make the estrogen and progesterone anymore. All right. What is menopausal hormonal therapy, or commonly HRT, hormone replacement therapy, is another name for it. And it's really just referring to the administration of estrogen. And if you still have your uterus and haven't gotten a hysterectomy, we would also be adding in progesterone to make sure that we're decreasing the risk of your endometrial lining thickening. And the administration of this is to help mitigate some of those symptoms that we started talking about. It is the most effective treatment for hot flashes and night sweats. We see that replacing your hormones, we get up to 90% improvement with those symptoms, which is significant. And also, of course, helps with quality of life as a result of that.
Yeah, yeah. And this is where hormones can help with sleep outside of the progesterone, where it's like if you're having night sweats, hot flashes at night that are disturbing sleep quality, sleep is like the king when it comes to quality of life. And so if that's messed up, your mood's messed up, and it can be really, really life-changing for some women where it is affecting their sleep or just their quality of life in general. And then I want to repeat what you just said, where estrogen is kind of doing a lot of the heavy lifting in hormone replacement therapy. Progesterone has benefits for women, but you have to be on progesterone if you have a uterus. It has to be there to protect the uterine, the endometrial lining. Without it, if you have unopposed estrogen, you worry about thickening of that lining. And I know you said all of that. I just wanted to pause because there's always questions that come up about
Yeah,
that.
it's really important.
Okay, so when is MHT, which is menopausal hormone therapy, when is it actually indicated? When do we want to think about using it? So hot flashes are one of the biggest indicators, hot flashes and night sweats that are affecting quality of life. So if they're moderate to severe, or if they are affecting your quality of life. The prevention of osteoporosis. So thinking about your risk factors for osteoporosis. History of eating disorder, being underweight, being a woman in general is a risk factor for osteoporosis. osteoporosis. So looking at the risks there, we don't use hormone replacement therapy as necessarily a treatment for osteoporosis if you already have it, but the prevention of it, it can be very, very useful. Also, if a woman goes through early or premature menopause, that's before the age of 45, then your OB will very likely talk to you about hormone replacement therapy. Vaginal dryness, or if you're having recurrent UTIs, when you're going through perimenopause and menopause, the estrogen fluctuations and really the reduction in estrogen that the tissue of the vulva is exposed to can create issues with pH balance, can create issues with just dryness and moisture in general, which can increase your risk for UTIs. And so that's another possible indicator. And then other genitourinary symptoms as well. I have a different slide for this one. So there's indirect benefits from hormones as well. So they can help with sleep. Like Dr. Williams was saying, progesterone is calming to most women. There can be exceptions, but progesterone can help with sleep quality. Mood. So hormones can actually help to reduce or treat depression that started due to hormone fluctuations. So if you had depression since you were 12, we're not thinking about hormone replacement therapy for you because there's another etiology going on there. But with women, especially who notice mood changes that started in perimenopause, hormone replacement therapy can sometimes benefit. Energy levels. Hormones, estrogen and progesterone aren't like they're giving you like caffeine. However, if you have sleep issues because of hot flashes, mood changes because of hormone fluctuations, all these things can for sure affect your energy levels, which can then affect your desire to exercise or be social. And it can be this feed forward cycle there. Concentration, we've seen improved benefits from hormone replacement therapy, and then quality of life in general.
So, as Dr. Mary just said, hormone replacement can help prevent osteoporosis and fractures. So, osteoporosis is referring to the weakening of bones that makes them more likely to break. And we know that osteoporosis is linked to higher mortality. So, if you have a hip fracture, for instance, you have a 5 to 8 fold risk of mortality 3 months after you have a hip fracture. So, really significant thing that we are talking about here. And 30% of women at age 65 have osteoporosis. So, we know that hormone replacement can help prevent this bone loss and reduce our fracture risk. So, it can reduce the risk of all fractures by 26%, which is substantial. And then we see specifically with hip fractures, reduces it by 28%, and vertebral fractures by 37%. And what we see here in this graph is the use of estrogen and at higher doses increases bone mineral density in the lumbar spine. And so you can see that bottom yellow line is placebo. So a significant improvement here with the increase of bone mineral density.
Yeah. And I want to echo, we need to care about osteoporosis a lot more than I used to care about osteoporosis. I remember being,
Same.
in your 20s, you're like, who cares about osteoporosis? It is so important. Where one of the facts that I like to talk about is if you break a hip as a woman in your 70s, about 1 in 20 women will die within 2 years of a hip fracture. If you break a hip at the age in your 80s, it's 1 in 10 women will be dead within 2 years of a hip fracture. And in your 90s, it's 1 in 4, 1 in 5 women will be dead if they fracture a hip at the age of 90 or older. Those are staggering numbers, and not to like induce fear or anything because we can prevent it. Number one, it should be empowering. We have, tools to treat and prevent osteoporosis. But really care more than I did in my 20s. That's all I'm saying.
Same.
Okay, so hormone replacement therapy usage has actually declined. And Dr. Williams is going to talk about one of the landmark studies called the Women's Health Initiative that really was a pivotal point in this decline. But prior to the WHI, 25 to 30% of women were on estrogen, were on hormones. It's decreased by about 80% since 2002, which is a huge decline. And estrogen now is only prescribed to about 3 to 4% of peri and postmenopausal women. That number is increasing for sure with education. And we really want to stress that hormone replacement therapy can be safe and effective when it's prescribed to the right woman correctly. And with everything, there's risks, right? You have a risk getting in a car, you've got a risk taking any medication, you've got a risk taking any supplement, you have a risk eating foods. So we're going to talk about that, but we don't want it to be this thing that feels like it's a no-no.
So, the Women's Health Initiative was a study published in 2002, and it set out essentially to look at the hormone replacement therapy and risk and benefit for chronic health conditions. So, it included 27,000 women, the ages from 50 to 79, average age was 63, and this was the first randomized controlled trial that we had. So, it was a really important study. They separated women into oral estrogen plus progestin group versus just estrogen and then placebo. And so the study was actually stopped early because they found an increased risk of breast cancer in the group that was given the estrogen plus the progestin. And so this instilled a lot of fear in people. And overall, the data was originally misinterpreted, unfortunately, and scared people into thinking that hormone replacement gives you breast cancer. And so that's what led to that dramatic decline that Dr. Mary just spoke about. But when we look at the study a bit further, what we really see is what is listed here on the slide is that there was an increased risk of breast cancer. It was an extra 6 cases per 10,000 women after 5 years of hormone replacement therapy. And then in the estrogen only group, there was actually 5 fewer cases per 10,000 women after 7 years. So the risk is much smaller than we originally thought. And it's also important to note that this would vary by regimen too. So this only used oral estrogen and progestin, which is not what we most commonly use. We'll get more into that as well. But there is some potential risk, but overall, it's less than we initially thought, and it is safe and effective for a lot of people. So.
Yeah. Yeah. And just echoing, it was the estrogen plus progestin group. We don't prescribe progestins regularly. We prescribe progesterone, and we'll talk about what that is. But progestin, they used an MPA, which very few doctors will use currently. It's still an option for some women and has, reasons to use it. But that is the group, the one that had the estrogen plus the progestin, who had extra 6 cases per 10,000 women after 5 years. Estrogen alone did not see that increase and actually saw a little bit of a decrease there. And one woman asked what was the typical menopause age for women during this study. The typical age for menopause hasn't changed since 2002 to now, so it's still around 51 on average for women. The average age, though, of the woman in the study was 63. And that's something that Dr. Williams noted where, typically we're prescribing hormones ideally. You're going to get your best bang for your buck in the perimenopausal years, earlier being better in perimenopause still, versus we hesitate to prescribe hormones after 10 years post-menopause. So if your last period was at the age of 50, we would hesitate to prescribe after the age of 60, and earlier is definitely better. And this is where you'd want to talk to your doctor about your risks and benefits if it has been more than 10 years, if it actually makes sense or not. But definitely we know that risks reduce the earlier you start.
And that was a big issue or limitation with this study, just to reiterate, because the average age was 63. So these people were likely far past perimenopause and menopause. And so they already had a lot of health conditions and were past that more safe age that we know to actually start hormone replacement.
Yeah, which is good that so this is stratified. So we're just looking at ages 50 to 59 here. And they did see an increased risk of breast cancer with the progestin plus estrogen group. And again, we don't use progestins much in practice at this point.
So, what we know and have good data on this point for hormone replacement is that, as we just talked about, there's a potential increased risk for breast cancer. And there is also a potential increased risk for stroke and clots, especially when we are using oral estrogen. And then there is good data to show that there is a decreased risk of type 2 diabetes, osteoporosis, as we talked about, colon cancer, and overall mortality when we are using hormone replacement.
Yeah, the colon cancer one always surprises people, but it's a really interesting one and one to know because colon cancer is one of the most common and most deadly forms of cancer that we see. And most people will say that you have an increased risk of breast cancer. We don't necessarily think that estradiol hormone replacement therapy causes breast cancer, but if you have cancer that's there, could it potentiate it? Could it make it worse? Could it increase the development of it? Potentially. And this is still something that there is a question mark around. So we want people to understand that there are potential risks and we should be weighing those accurately for people in making informed decisions.
Yeah, exactly. And so what are the contraindications for hormonal replacement therapy? So if you have a history of hormonal cancers like breast cancer, uterine cancer, that would be something that we would not want to use hormonal replacement with. If you have established cardiovascular disease, that is also something that we want to be mindful of. Estrogen can sometimes make the any pre-existing plaque unstable, so we want to be really aware of that. Previous strokes, clotting disorders, transient ischemic attacks, high blood pressure, liver disease, bleeding that we, can't figure out what the cause of that is. Those would be things that would be warranting further investigation and not using hormone replacement therapy at this time. And also, as Dr. Mary said, that we want to make sure that we are timing hormonal replacement therapy correctly to maximize benefit and reduce risk. So we know that starting hormonal replacement before 60 years of age or within 10 years of menopause will give us more of the benefits and reduce our risk of, things like stroke and heart disease and things like that. All right. So the right hormone replacement therapy approach for you, like Dr. Mary also said, we really want to make sure that we are looking at the whole person, looking at your own personal history, your family history, your symptoms, and making sure that they fall in line with warranting hormonal replacement. Something also that we will do is making sure we're regularly monitoring your symptoms and labs as we go throughout working together. And we're always trying to use the lowest dose of that is effective for you. And as far as what we are mostly using in practice is we are mostly using transdermal estrogen, which reduces the risk of stroke, plus micronized progesterone, not the progestin, as Dr. Mary said. So those are the most common ones that we use in practice to minimize risk, but everyone's different with what works best for them.
Yeah. Yeah. And there's did you touch on pellets at all?
No, not yet.
Okay.
Yeah. And so as far as the different forms that we use overall, like for estrogen, as we talked about, mostly using transdermal, so creams, patches would be the most common. There's also a ring that gives you systemic estrogen. And then there's low dose estrogen therapies that are really helpful for those genitourinary symptoms. So if you're having vaginal dryness, pain with sex, if you're having recurrent UTIs, it's really what we want to be focusing on is using the low dose vaginal estrogen, which is very safe. We get very little systemic absorption here, and they can actually reduce the risk of UTI by over 50%. So very important that we are looking at those if you fit in that category. And then for progesterone, we are using oral progesterone nightly because it does often help with sleep. We do not want to be using topical progesterone because it will not be protecting your uterine lining. So very important that we're using oral when we're using progesterone. And then for testosterone, I know we haven't talked a lot about that, but we're usually using topical here, a cream or a gel. Um, and then for pellets, you guys might have heard of pellets before, but this is when they are injecting estrogen or testosterone typically into your body in the form of pellets. And this is something that we don't recommend. It is usually giving you very high doses of these hormones, and you're stuck with that dose for months. We can't take it out. And so if you're having, side effects, it could increase your risk of some of the things that we talked about too if we are under overshooting.
Yeah. I don't know how many women I've had come to me and they're on like month 2 of testosterone pellets and they're like, I don't like how I feel right now. Some women feel great, so I don't want to,
Yeah.
like, obviously, I'm getting the women that don't want to continue with them. But do know that pellets are typically much higher dosed, and you are stuck with them after they're put in for 3 months. And then the other thing I wanted to highlight again that you said is low dose vaginal estrogen. So not systemic estrogen, but low dose vaginal estrogen, which is used, like Dr. Williams said, to treat dryness, genitourinary symptoms. That one can be used at virtually any age. So we don't have to stop that at the age of 60. If you've never been on hormones before and you're 75, talk to your doctor because that one is one that we're not worried about a lot of the things we're worried about with estrogen in terms of risk. So it's never really too late to do low dose vaginal estrogen. Okay, bioidentical hormones. What's the deal? People always ask about this. Bioidentical came about originally as a marketing term, and there was a celebrity that was touting it. And what people think that it means is that your estrogen looks exactly like the estrogen that you produce in your body. So, like chemically the same, and that this is better for us because it looks exactly like the one in our body. Estradiol that comes from hormones, whether it's a patch or a cream, whether it's compounded or commercial, if it's estradiol, they're actually biosimilar, which means that they look really similar to the estrogen that you produce, but none of them are actually identical. The reason I bring it up is sometimes this is still used as a marketing term and it's used incorrectly when compounding pharmacies, especially, are saying you have to use a compounding pharmacy because we're the only ones that produce bioidentical hormones. You can get biosimilar, bioidentical, whatever you want to call it, hormones through CVS, Walgreens. They can go through your insurance. They can be way more affordable. There's transdermal estradiol patches that are bioidentical or biosimilar, oral progesterone that you can get through your insurance as well. So just be cautious if you go to a practitioner who says you have to do compounded because they want to make sure it's bioidentical. First of all, not true. Second of all, it can save money. And then there's also concerns with compounding where you want to make sure you're getting the same exact dose every time. And in my opinion, the commercially available ones, cheaper, more reliable, you're getting the same dose. It just seems like a no-brainer to me. And we'll go through some of the myths, but one of the biggest myths that I've heard as patients come in is, oh, well, you need to test your estrogen and progesterone and testosterone levels before to make sure that you're dosing it correctly based on you and your body. And they're using bioidentical in that fashion, that we have to like design a very specific dose for you and that a compounding pharmacy is needed to do that. That is not true. If a woman is in perimenopause or menopausal, most of the time we actually don't have to check estrogen and progesterone levels because they're going to be fluctuating like crazy. We don't know where they are. And you're not dosing based on a level because if you are, you saw in perimenopause, which one are you going to choose that you're based off of? And it's just not an evidence way to practice as well.
All right, menopause and weight gain. This is one of the most common things that I see with women is, weight gain when our hormones start to fluctuate. And so we do see that when our estrogen overall decreases, we have a change in body composition. We tend to start to favor weight gain in our abdominal region. And so we see then menopause that we gain an average of 6.4 pounds and our waist circumference increases by 2.3 inches. So, on to the next slide.
Dominic, you
Oh,
stay
yeah.
here.
Yeah.
Does menopause cause weight gain? I guess this is, you should be on
Yeah,
this.
yeah, yeah. Weight gain is common here, as we just talked about. And one thing that we hear a lot is, well, my metabolism must have changed. My metabolism has changed. I'm gaining weight. And this is a study that actually looked at how our metabolism changes as we age. And so we actually see that your metabolism does not change until after the age of 60. And even then, it's a very small decrease that we see at 60. And so it's actually not that your metabolism or your ability to burn calories changes. We actually see that it is likely due to other changes, other things. So one of those things is physical activity. So what we're looking at on this graph is women are on the right-hand side here. We're looking at the amount of women who meet the physical activity guidelines as we age. And so we see that, the blue and light green graph are really where we're looking at perimenopause and menopause. And so we see here that about 17 to 23% of women are meeting the physical activity guidelines at this time. And so part of the weight is likely due to decreased physical activity. This may very well be because you're not feeling well. You might not be sleeping well, your mood might be all over the place. You might also, be consuming more calories because you don't feel well. So it's kind of like this vicious cycle. So there's a lot at play here, but we can clearly see that decreased physical activity is likely playing a role with the increased weight that we're seeing at this time.
Okay, let's go through some myths. One of my favorite things to do is myth busting. One of the myths is that, okay, if you're going through perimenopause, you should use wild yam cream because it's natural and it can help with symptoms. BS. Like, we don't like BS. That's the BS category. Wild yam cream is not effective. It's not tested to actually be effective for perimenopause. And if we have something that is tested and we know is effective and has been studied in women, why would you use something that is subpar? There's no benefits to it and potential risks as well. Another one would be that menopausal hormone therapy helps with weight loss. So, as Dr. Williams says, women can gain weight in these years, but it's usually due to reductions in physical activity, eating more calories, a combination of the two. And it may be because you don't feel great because you've got night sweats and you're not sleeping and you're waking up tired and you have more cravings, blah, 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 blah. And that's not to minimize that. Like, those are real things. However, women come in and they're like, I want to be on hormones because I want to lose weight. And hormone therapy will not lead to weight loss. Hormone replacement therapy can potentially help with the redistribution of fat away from the midsection to the hips, butt, and thighs, but it's not going to cause actual weight loss. So, putting some expectations there. Compounded bioidentical hormones are safer than a commercially available formulas. I already talked about this, but there is nothing that says that they are safer from a compounding pharmacy. I actually would argue the opposite, and I've seen women come in that are supposed to be on 3 milligrams of testosterone, and their testosterone's 250. I saw that this year. They're just not as reliable because they're doing individual prescriptions for each person versus doing a huge batch commercially. And then there's going to be more regulations around commercial manufacturers as well. Okay, first I want to go into, actually, no, let's go through. We're going to talk to you about how we work with women in terms of one-on-one if you're looking for hormone replacement therapy or weight loss or other things that we treat. And then right afterwards, we're going to do question and answer. So if you have questions, put them right now in the Q&A box and we'll get to as many as we can. Other integrative practices charge up to $2,500 for your first visit. Out-of-pocket lab testing can be up to $7,000. Literally just talked to somebody today who quoted them $7,000 just for the lab work. Monthly supplement costs can be upwards of $300 for practices, which gets you to around $5,600 to $9,800. And we're just talking about one visit and all of your workup there. We're not talking about subsequent visits either. These are actual real numbers from an actual clinic within the last 2 years, too. At Modern Med, our program gives you an initial meet and greet that's with a practitioner, so you can actually schedule something with Dr. Williams for today or tomorrow. It also gives you unlimited portal access. So between your appointments, you can message Dr. Williams, you can get answers. You don't have to wait until your next appointment to troubleshoot dosing, symptoms, things like that. It comes with one monthly visit. All of your labs can go through insurance if you have a good PPO insurance plan. If you have an HMO, we do have affordable cash-based options. We focus on essential testing that's evidence-based, so we're not going to send you to all of these eclectic lab companies to get saliva, urine, stool tests, all of the things, especially for hormone replacement therapy. It's not necessary. It's not going to change treatment. We want to do things that, like, we're going to do comprehensive blood work panel because we know that certain factors increase your risk for cardiovascular disease. So we're going to focus on the things that will initiate the biggest change for not only your lifespan, how long you live, but also your health span, how well you live, and your quality of life. You have a dedicated patient care coordinator that's full time. Jean is our front office person. She's been with us for, I always say it wrong, I think it's 5 years now, and she has reviews of her own on Google because people love her so much. You can text her, you can email her, you can call her. Sometimes you'll hear roosters on the phone when you talk to her, which I love because I don't do that much, but I think it's the
Same.
best. And we have a team of doctors who can view your case. So we do weekly, bi-weekly team calls where we talk about, hey, if somebody's not getting results, why don't we have more eyes on this case to discuss it as well? We do a personalized supplement review, and our goal is to get you on as few supplements as possible and to make sure that you're only on things that will actually give you results. One of the biggest things I hear when people work with me is, wow, I'm saving money on supplements right now. And none of our doctors benefit financially from supplements that they recommend themselves. So you don't have to worry about a bias there, which is how most functional medicine and integrative practices actually work. We provide super bills for reimbursement, so you can go to your insurance. Most good PPO insurance plan will do a partial, some will do none, some will do all of it, and that's very much dependent on your personal insurance. So if you totaled all of that up in terms of the value, it's around $4,000. We don't charge that. Our typical price outside of this webinar is $467 per month if you did a 3-month commitment. We also have a lower price option if you did a 6-month commitment. And today we're doing a special that is $389 a month for the first 3 months. So it's 20% off. It's now until this Friday at 5 p.m. So you just have to call, email us, and Dr. Williams has times available if you want to chat with her to see if it is the right fit with you. But make sure to do that before Friday at 5 p.m. And as I promised you guys, even if you don't want to become a patient, we're doing 20% off of all supplements for a full year. And this is how to claim that. If you want to just take a screenshot of it, it'll give you instructions on how to do that and how to sign up. This is our phone number, so feel free to screenshot this, write it down. And then we're going to start with Q&A right now as well.
All right. So, one of the questions that came through is what are your thoughts about taking progesterone after a total hysterectomy for the benefits of progesterone, like mood, sleep, and brain health? And so, as we talked about, progesterone is not needed if you have had a hysterectomy. But if you are finding benefit from it from a mood and sleep standpoint, by all means, I say that it's fine to be taking it as well.
Awesome. Um, I forgot to talk about, so
Oh,
I'm
sorry.
accepting a few more, this is my fault. I'm
Yeah.
accepting a few more patients. I know I've been talking about Dr. Williams. I'm accepting a few more patients in my concierge model. It's a little bit different of a model, and there's no discount right now. So it's just if you want to work with me, you can visit our website, you can schedule a complimentary meet and greet. It's a different price point, it's a different structure than Dr. Williams, but that's there if you want to take a look at it. You got another
All
Q,
right.
Q&A?
Yeah. One question here is how does factor V Leiden affect taking HRT? So this is a genetic condition that makes you more at risk for clotting, essentially. And so in this type of situation, I would usually want you to have a hematologist on board and to coordinate care together to see if it would be a good fit for you. And of course, look at your history of clotting and test certain markers. But there are certain forms that could be safe for you, but it would just require some coordination.
Yeah, agree. And transdermal has less of a risk for clotting than oral. And so talking to the hematologist and making a joint decision makes sense. I agree with that. What are your thoughts on taking birth control as a form of HRT? The patient does not need birth control to prevent pregnancy. Patient is only taking birth control for HRT purposes. Birth control can be used in the treatment of perimenopause and menopause. You just want to see, is it the best option for you? So this is going to be, again, informed decision. If you're taking oral birth control, you're obviously taking oral estrogen. And so we want to see, is oral estrogen the best use for you, or is transdermal a better option? And are you getting results? And what are your family history, your risks, and all of that? It's an option. So we have tools. You want to have a bunch of tools in your toolbox and just say, is it the best option for you or for whoever this is?
This is a good one. As you know, there are so many lose weight on menopause programs out there. They say it's all about your micronutrients. You're probably not eating enough, and you're definitely not eating enough protein. They have the magic solution. What are your thoughts about these claims? Can you talk more about weight gain? This is a great one. This is extremely common, as you said, and I am not a fan of these claims. I think they are ridiculous. And really, ultimately, what it comes down to with weight management is calories in versus calories out. So we need to be in a calorie deficit to lose weight. And so it really comes down to nutrition and exercise is the main things that we really focus on when it comes to weight management. Supplements and herbs are not ultimately going to be very effective. Fad diets are not going to be very effective, especially in the long run. You might initially get some weight loss, but you're ultimately going to gain it back. So that is what I think on that. And Dr. Mary might have more to say too.
No, I totally agree. And we did a whole webinar just on weight loss.
Yeah.
So if you're interested in that, go to our website, go to our blog section. It was me and Dr. Williams. We went in depth about weight loss, the myths around weight loss. So please check that out. I think it's on our podcast too, on Apple Podcast. But completely agree. And that's one of the things that both Dr. Williams and I treat all the time is how to lose weight effectively, long term, like have durability in your results and using evidence-based medicine because we have so much that works and it doesn't mean that it's easy. Like we don't want to gaslight. It doesn't have to be easy, but it can be simple. So those two things can coexist. So Sharon said, thank you for the webinar. You're so welcome. We hope you guys enjoyed it. Who enjoyed the webinar? If you learned one thing, if you can raise your hand so we can sleep at night. Oh, thank you. Yay. Awesome. This person is asking, does perimenopause exacerbate gut issues? So perimenopause is that period of time where there's these big fluctuations that can happen. And so some women will experience, if they have gut issues, fluctuations based on the changes in hormones because estrogen and progesterone do play a little part in motility of the GI tract. Some women won't. It's not like it's this super, super common thing. What's really interesting though is that IBS rates are much higher in women before the age of menopause, compared to men. Whereas after the age of menopause, men and women have more similar rates of irritable bowel syndrome. So it actually looks like you may experience benefits after those crazy fluctuations happen if you have irritable bowel syndrome. Obviously, that's a niche percentage of the population.
Kind of hand in hand with that, do you think it's important to consider gut health before starting hormonal therapy? Do you do gut testing and a GI consult? And so I ultimately no, unless you are having digestive symptoms, I would not do any digestive testing or a consult. I don't think that's something that is needed to look into before starting hormonal therapy.
Yeah, totally agree. I'm guessing this person's talking about like beta-lactam and estrogen metabolism, which a
Mm,
lot of functional practices will talk about in terms of the gut microbiome influencing it. Um, I call that mechanistic medicine, where it's like, okay, each part of that can be true. Where, yeah, does your gut microbiome have the ability to break down estrogen? And, is beta lactam a thing? Yes, it is. But is it going to change clinical outcomes to do, let's say, a stool test and see how you're quote unquote metabolizing estrogen or a urine test of metabolizing estrogen? Is it going to change your outcomes? Is it going to make you healthier? Is it going to change how we decide to treat you? I would answer no for all of those, so I don't think it actually makes sense to practice in that way.
agreed.
Any other questions that we're going to answer here?
Mm.
Somebody asked if I agree with certain doctors' protocols. I don't know their specific protocols, so I can't speak on them. If you have questions about something specific, then we can try to answer that.
One here, my mom's almost 74 and has so many menopause related symptoms that were never treated. She has chronic pain, migraines, and heart issues. What do you recommend for older women? That's a tough one. Age 74 is past the obviously 10-year mark, past menopause, and so she wouldn't be a candidate for hormone replacement at that point. So what do we recommend? It would really that one would require, further in-depth approach to looking at that person and her health history and all of that to figure out what are other ways that we can help support her.
Unless she has vaginal dryness, then potentially low
That
dose
would be one.
vaginal estrogen, but
Yeah,
if it's
yeah,
other things, then totally agree.
yeah.
What type of magnesium would you suggest to support menopause? Magnesium is not a treatment I recommend for menopausal symptoms. So magnesium, I don't see it's going to be helpful for hot flashes. It's not going to be helpful for vaginal dryness. Can magnesium be helpful for other things? Like totally. I use magnesium for constipation, but not, it wouldn't, menopause is not an indicator for magnesium specifically. Save you money. Does being on hormone replacement therapy give you thrush? So thrush is an infection caused by usually candida. And no, that wouldn't be like one of the common side effects of hormone replacement therapy. So I would look in to talk to your doctor about potential other things that could be going on.
Another one, do you agree that strength training is the way to go during perimenopause? I love this question. I should think strength training is the way to go throughout your whole life, not specifically in perimenopause, honestly. But one of the main things is this, of course, goes back to the more muscle that we have, the more we are supporting our body as we age for protecting our bones, our heart, our brain. And so it's really important that we are doing strength training and maintaining our muscle mass as we age.
Agreed. It's actually not live yet, but I just did a podcast with an exercise physiologist who specializes in women's exercise and women's health. So if you're not following the Modern Wellness podcast yet, you're going to want to listen to that one if you have that same question. Spoiler alert, because you're on the webinar. Exercise doesn't need to change in perimenopause. Exercise, like the recommendations don't need to change. Strength training, like Dr. Williams said, it should be an integral part throughout an entire woman's life, but we don't have to view perimenopause as this time to like change your diet, intermittent fast, change your exercise routine, take all these supplements, do all this stuff. It doesn't have to be that complicated. It can be really simple. It doesn't mean that it's easy. So again, we can have that duality there, but no need to change exercise just because you're in the perimenopausal years. Awesome. All right, well, we're gonna wrap it up with that. We're gonna give you a couple more minutes to eat your lunch. Again, Dr. Williams is available today, Wednesday, tomorrow, Thursday, I think Friday as well. If you
Mhm.
guys want to call and do a brief like meet and greet with her, if you have additional questions just specifically around can she help you, that's what those calls are for. If you know you want to become a patient, just email, call us, and make sure you sign up before Friday to get that discount that's there. And we really appreciate you guys joining the call. We know it's midweek, it's midday. Appreciate your willingness to stay on for this long. And we really hope that you learned something. We want to be, again, that signal amongst all the noise that is social media. So stay in touch, email us if you have questions, and if we can be a resource, please let us know. Thank you,
So,
Dr. Williams. Yeah.
yes, you're very welcome. It was so great to be here. And please reach out if you have any other questions. Happy to jump